I would like to share in the next 15 minutes. I was told the time is very strict, so I'll make sure I stay on time. And sorry, I would be speaking English because you would laugh at my French. Anyway, I would like to share with you some of the results, of course, that we gathered during the LungSafe study. The title is Current Practice, so the LungSafe data were collected about 4.5 years ago. So it's maybe not super current, but I think it's quite representative of what's going on in our ICUs. My conflicts of interest, which are not related to the present talk. And when we think about the LungSafe data, we always have to consider that for the good or for the bad, we had, well, I think for the good, we had a worldwide participation of ICUs. So somehow the LungSafe represents a global picture of what's going on in our ICU. And I think many of us reading some of the LungSafe findings wonder whether these really apply to their own ICUs. But still, I think it's a good starting point to think about our clinical practices. So just to briefly recall what we are able to say, we were able to collect data on some 3,000 patients with ARDS, and specifically we focused, whoops, sorry, I thought that's pointer, and specifically we focused on these 2,800 patients with ARDS in the first 2 days since their ICU admission. We had a number of patients that were invasively ventilated, which we will see in the first part of the talk, and some patients with non-invasive ventilation. So at first, I think the starting point is always how do we set tidal volume. Every conference we go at, we see the 6 ml per kilo slides, and we think we are sick of hearing that we should treat our patients with a tidal volume of 6 ml per kilo, but it's really not happening. We are much closer to the 8 ml per kilo range, and really this is highly statistically significant, but clinically not meaningful, I think, the adjustment of tidal volume depending on the severity of the disease. And would there have been room to decrease tidal volume in these patients? I think there was, because if we think, for example, and if we take a look at respiratory rate, we see that still there are relatively, I would say, low to moderate respiratory rate used even in severe ARDS patients. And I know that there are data showing that also respiratory rate can be harmful, but the only way not to decrease tidal volume, if we aim at a given PCO2, would be to increase respiratory rate. And the other aspect which I would like to emphasize is the fact that you clearly see that despite the fact ARDS is grading of severity is focused on oxygenation, so we look at PF ratio to grade the severity of ARDS. Also, CO2 elimination is heavily impaired, as you see by the increasing minute ventilation used in these patients. This slide only shows the fact that we do not really adjust tidal volume according to the severity of the disease, and that if we call protective ventilatory strategy what is below 6 ml per kilo, only about 40% of our mild, moderate, and severe ARDS patients are receiving a protective tidal volume. In terms of targeting for minute ventilation, and if we recall that the goal of ventilation is CO2 elimination, here we clearly see a separation between patients with mild and moderate ARDS and patients with severe ARDS. So in these patients, perhaps due to the impaired respiratory mechanics and to the more difficult protective achievement of a protective ventilation, these are the patients in whom we tend to tolerate a degree of permissive hypercapnia. Still, the median and the mode of this distribution is quite close to 40 millimeters of mercury, meaning that in most patients we still aim to achieve normocapnia despite the need for a very high minute ventilation. And I think it's also something we should consider, the fact that perhaps sometimes we can ventilate a little bit less the patient with some accepting a bit of a trade-off on CO2. I will go back to the use of neuromuscular blocking agent towards the end of my talk, but we had a small fraction of patients, only about a third, which were receiving neuromuscular blocking agents in severe ARDS, and about a quarter of these patients exhibited some forms of spontaneous breathing, meaning that they were either in pressure support or that anyway the respiratory rate measured was higher than the set one. And as we see, the use of spontaneous breathing is associated with a further increase in tidal volume. So I think we should always keep in the back of our mind that whenever we let a patient breathe, we somehow pay a price to the freedom we are giving to the patient, which is the loss of control over tidal volume. This is not statistically significant, but the trend is clearly there in all the subgroups of ARDS. What about plateau pressure? Plateau pressure is, I would say, in a rather safe range. So it's around 26 centimeters of water on average in the severe ARDS patients. So we are doing a good job in terms of plateau pressure, I would say, except that in many patients we do not measure plateau pressure. Only in about 50% of even severe ARDS, plateau pressure was charted in the lung-safe CRF, so we assume that if it was not registered that it was not measured. However, and the plateau pressure as opposed to tidal volume clearly separates patients with mild, moderate, and severe ARDS. However, if we look at the main reason for a low plateau pressure, it's not only the use of a protective ventilation, but it's rather, to me, the use of relatively low level of PEEP. So there's a huge debate in the literature going on what is the correct PEEP value to be set. Clinicians do not seem to adjust very much PEEP according to severity of the disease. You see that even in severe ARDS, mean PEEP set was 10 centimeters of water, and this is the PEEP level that was set according to each FiO2 value. The red line represents 10 centimeters of water of PEEP, and these are the patients on an FiO2 of 1, breathing pure oxygen. So half of the patients that were just breathing oxygen had a PEEP level of 10 centimeters of water or lower, which is something that made me think quite a lot. Concerning adjunctive strategies, here I'm preaching to the choir because we have the two principal investigators of these very elegant studies which finally were positive. We always complain in critical care, we don't have positive studies, blah, blah, blah. We do have here positive studies showing that prone position and neuromuscular blocking agents are beneficial, improve outcome of patients with moderate to severe ARDS with a stronger signal for severe ARDS. And we apply these measures in 1/3 of the patient or 13% of the patients. This is, for example, one field in which there is a clear geographic separation. We are rather good at putting the patients prone in I would say, south of Europe, but still, even in Italy, we achieve 50%. So about every other patient gets this adjunctive measure. Does this matter? Does the way we set the ventilator matter on patient outcome, or is it just something good for me and having a trip to Paris, come here, give this talk? Well, it looks like it does matter somehow, because when we've looked at the predictors of mortality in our patients, we found some usual suspects, so age, neoplasm, which makes us quite confident about the robustness of the data. However, we also found that positive end expiratory pressure and peak inspiratory pressure, which was not, because plateau pressure could not be put in the model due to lacking data, were associated with an increased risk of death for peak inspiratory pressure and a protective effect for Peep. So after normalizing for our other values, other covariates, Peep exerted a protective effect on mortality in the cohort, was associated with a decreased risk of death in the lung-safe cohort. We cannot make any cause-effect relationship claim. And this effect was particularly evident in the moderate and to a certain extent in the most severe ARDS patients. I think the lack of significance here is due to the fact that this cohort was relatively small, but the signal is in the same direction. And we also reinforce the importance of driving pressure. I will not say anything about plateau because I only have 3 minutes left, but I would like to reinforce that our data are remarkably consistent with other findings, for example, from Marcelo Amato, showing that driving pressure above a given level, which which our data showed around 10 to 12 centimeters of water, was linearly increased with greater risk of death. So we are doing a good job in keeping the plateau pressure low. But if we keep plateau pressure low because PP is low and driving pressure is high, we are not really protecting the lungs. So I think these data once more emphasize the importance of monitoring driving pressure. And perhaps maybe it's a good point for discussion, targeting this as a value for setting mechanical ventilation. One last word about non-invasive ventilation, but you might be thinking, well, his talk is about severe ARDS. Why does he show up with data on non-invasive ventilation, which is recommended for mild ARDS? When we looked at the use of non-invasive ventilation in our patients, we found that really the incidence of use of non-invasive ventilation was somehow around 15%, no matter whether the patient had a moderate, mild, or severe ARDS. But I'll skip through this for the sake of time. I think this is the finding I'm most aficionated to in the lung safe. The fact that if you look at invasively ventilated patients, PCO2 increases with the increasing level of the severity. You would expect this. Greater dead space, more difficult to ventilate patients. More severe the patient is, the higher is the PCO2. But these patients with severe ARDS have a low PCO2 on non-invasive ventilation, meaning that they are inducing, and likely meaning that they are inducing an injury on their own lungs, because this PCO2 will not stay low for free. There is a cost the patient has to pay to keep the PCO2 such low, and it is ventilator-induced lung injury. This is perhaps the reason why non-invasive ventilation was associated with an increased risk of death in patients with more severe ARDS. So in conclusion, I think we are going in the right direction, but we could still decrease a little bit the burden of mechanical ventilation which we impose on our patients. And some of these are really low-hanging fruit. It's just a matter of turning the ventilator knobs for a slightly lower tidal volume, slightly higher respiratory rate, and perhaps accepting a slightly higher PCO2. When plateau pressure is measured, It rarely exceeds 30 centimeters of water, but this is also due to the fact that we use relatively low levels of PEEP, and we tend to correct hypoxia mainly by increasing FiO2. I made it in the 15 minutes. I'm very glad of it, and thank you so much for your attention.